what I have here kind of reflects why I just keep on coming back and coming back. And I'm a big believer in the products and services promoted by this company because it helps my patients, and we're dealing with life-threatening problems. So this reflects how I feel about how it needs to be done and the paradigm we need to be traveling towards. So it's about friends and family. Because we're dealing with some very serious problems, sleep-related breathing disorders. And we're just going to share some knowledge today. This is about sharing some things. Some of you know about this. Hey, Marty, good to see you. A lot of you are doing this, some maybe not so much. But I'll just share some thoughts with you and a little something at the end that I kind of been working on. And we're going to talk about acoustic pharyngometry because it's essential. It's not optional because these are life-threatening problems. It's not like we're going to lose a tooth, we'll put an implant in. Do the endo, might work. We talked a lot about advancement today. That's all we heard about, mandibular advancement. Well, advancement doesn't always work, and sometimes it makes things worse. So I want to talk about how using acoustics that we can sometimes resurrect failing cases. And failure means life and death sometimes. And I want to just talk about the Respire Blue, a little something. If you're having problems with when you advance that mechanism, sometimes it gets a little loose and wobbly, and I'll just show you something I did. Maybe someone presented this before, I don't know, but I'll share what I did about it. And so the ties that bind us, yes, it's actually a song, it's a hymn. But the reason I'm here and the reason why a lot of us persist and we're working against the establishment, it seems, because we're talking about something that requires investment, commitment, but the reason we have to be passionate about this because people like Antonin Scalia, that was discussed today before we left. They found him dead with his CPAP machine unattached to his face. Like so many of our patients, they think it's an option, but the consequence can be disastrous in his case. This is a patient, she and her husband own a dance studio in Appleton, Wisconsin. Where's that? Well, it's just south of Green Bay and just north of Milwaukee. What? Houdini. Yeah, Houdini. That's right. Houdini is from Appleton, Wisconsin. So that's our claim to fame. There's a Houdini museum there. So anyway, thank you, Marty. Anyhow, she came to me with her TMJ problem, and like 47% of people with TMD problems, they have sleep problems. And she had, you can see on the pharyngometer, very collapsible airway, small. She had upper airway resistance syndrome. It was diagnosed, long story short, she's had 5 documented strokes. They all occurred at nighttime because she has a sleep and breathing problem. And her physician just kind of blew me off like, well, upper airway resistance syndrome, heavy snoring can't cause strokes. Well, it can cause autonomics to be on all the time. And again, it's a case that we worked through. It saved this gal's life. She's 25 years old, had 5 strokes already. This is my brother Tom, who was diagnosed with apnea. For 5 years I talked to him about it, and he couldn't tolerate his CPAP, and he kept on taking it off. He wasn't using it, and he died 2 months after that picture was taken. His dad and mom, my parents, are still alive at 99 and 94, 95. And he died of sleep apnea, complications due to sleep apnea. This is my daughter Rachel. I have sleep apnea, and she developed in her 3rd trimester of first pregnancy hypertension, dyslipidemia. She was waking up coughing and choking, and both her OB-GYN said, well, it's a high-risk pregnancy. We'll just hospitalize her. We sent her home with a monitor I got from the business, and she had mild sleep apnea. We fixed it. Her blood pressure came down, blood sugar came down in about a week. The point is, these problems are everywhere, and if you're phenotypically set up for these problems, your children are going to have them. But if I hadn't understood and learned what I had from being associated with sleep group solutions and becoming educated about this, no one would have figured out what's wrong with my daughter and just treated what comes up. Pardon me. This was her sleep study, and this is what her watermark. We retested her, and she had mild positional sleep apnea. Nonetheless, had I not been aware, her physician, the cardiologist and neurologist she was seeing, no one was talking about sleep. So again, these problems are everywhere. Last year in May, this guideline came out, And you can read through the lines. Matter of fact, this afternoon they presented some of this. It's like he was reading my mind or I was reading his. But this publication more or less said, hey, we've done enough work with these sleep appliances, and we can see from the studies that have been done that you guys have done a good job and proven to us that we have to talk about it now, that oral appliances have efficacy. They're equivalent to CPAP in many instances in their outcomes. And the summary recommendations are now that sleep physicians need to talk about it if the patient doesn't want CPAP or fails, not just if they fail, that it's truly an option. The grayed out areas, we'll just jump through those. But they're recommending that physicians seriously consider talking about oral devices in lieu of CPAP. So we're in the game now. We're in the game of treating a very serious medical problem. But it talks about qualified dentists. What's a qualified dentist? It's somebody who's not just hoping and praying the mouthpiece is going to work because the snoring is getting better controlled. A qualified dentist, in addition to working towards board certification, I think it's important, would be someone who's armed with technology like acoustic pharyngometry or ionometry. I just don't know how you do it otherwise. So who decides what a qualified dentist is? That's still yet to be defined, but it's important that we are qualified. The evidence shows that adherence rates for oral appliances are better than CPAP, and we use it more, and so people get better or equally benefit from oral appliances they do from CPAP. Quality of life outcomes show that oral devices are not inferior to CPAP. People feel better neurocognitively. Their risk for cardiovascular disease, blood pressure reduction is fairly equivalent to that with CPAP. So, and you see this term standard. A standard means that is written in blood. That is what you should be practicing. It's not an option. It's a standard of care. So when you see standards applied to these decisions made by this committee that was referenced this afternoon, that means we're in the game. We're in the game big time. CPAP versus oral appliances for systolic blood pressure reduction and diastolic, so it's all there. I'm not going to belabor the point. This is supposed to be somewhat. So these guidelines reflect the current knowledge, and they expect that physicians, this will change their behavior. They're going to give people an option, not if you fail CPAP, but as an alternative to it, because the efficacy is equivalent in many cases, from mild to moderate. So the bottom line is, now these are my thoughts. The demand for dental sleep medicine is going to grow. It's going to continue to grow, but our profession has to provide adequate care because outcome measures will be performed by objective bodies. And if we're not doing a good job because more and more is being done, and in general, the dental public are not as educated as they need to be because we see the consequence of people referred to our office. We need to control their education. We need to standardize some of what we do. And that's why I believe that talking about acoustics, giving people technology to at least assess what they're doing with these patients might be helpful. But we need, these dental sleep medicine is not being taught in dental schools by and large. It's not an ingrained part of the educational process, with few exceptions, UCLA, Tufts, and some others, but it's not the standard, part of the standard protocol in a dental undergraduate or graduate dental education. And it's my impression that acoustic pharyngometry and rhinometry will affect outcome measures very favorably. And if we take care and have good outcomes, our profession will benefit greatly financially, and the emotional rewards, the gratitude from our patients down the road. These are very grateful patients, and they stay with you. So it'll have a very favorable impact on our practice if we do good work. In that document, and some of you have read this, they talk about advancement is the only feature of appliances they evaluated. There was no recommendation for increasing the vertical dimension of occlusion. And we know that a percentage of people don't respond or do worse with advancement alone. So again, there's much work to be done, but that's exactly the issue that we address using acoustic pharyngometry. And I'll show you a case here shortly. You know, we take an oath. I'm not going to do the Latin thing, but first, do no harm. And some of you have seen these before, but I think we do harm when we tell a patient who's not responding to advancement, hey, this is the best I can do, I'm sorry. I think that without having technology to explore the option of additional vertical, not having a rhinometer to check the high upper airway, that's a key problem with lower airway instability. I think we can avoid harm by employing pharyngometry to evaluate dental sleep medicine patients who aren't responding to advancement. I think we can avoid problems. You can quickly resurrect refractory patients not responding to advancement. Now this is, we talk about, if you're not, OSA is a life-threatening problem. In a lot of dental sleep practices, they pride themselves that they use mandibular advancement devices, and we use this kind of appliance, and we use a George gauge, and we're waggers, we're wild-ass guessing, and we're proud of it. And I heard people talking about how this appliance is much more effective than this appliance, and what do? They all just advance the mandible. That's all they do. They either pull it forward with pink acrylic or push it forward with blue. You know, what's the difference? So talking about the appliance, it's the information you program into that appliance that improves efficacy, and a George gauge just keeps you at the minimal vertical. So I don't think this is, I think if you're treating sleep disorders in patients, you've got to be way beyond just, you know, wild-ass guessing it. Anyway, this is the case that came out last month in dental sleep practice. Carstensen asked me to write it. Some of you might have seen it, but I'll just go through the highlights. Again, it portrays what we can do. I've been treating this guy for about, I don't know, 7 or 8 years, and I'll let you read that, but he had, I think moderate sleep apnea, had done very well, kept his weight down, he was doing just fine. And we did a home sleep monitor in 2013. We're using the Respire Blue series. And we used an apnea link here, and it showed that the indices were normalized. The percentage of time below 90% was 1%, which is good. So the average saturation, 96%. No one's going to argue that that's not success. This is like 6 years into it. And in 2015, he came back. We came back every year, but we checked him again about a year and a half later, and things had elevated a little bit, but this disturbed me. He had a lot more time. He was in some oxidative stress. He was snoring a little bit, and his wife noticed it, and he was tired. He had a lot of autonomic system activation. Plus, he was too much of the time below 90%. So you know, his indices were sort of reflecting it. So we had to do something. But the problem was, what do you do with this case? What do you do? I'm saying to myself, I hope to God, you know, whatever, that he's going to I'm going to put him in the pharyngometer, which I've done in the past. I hope he's going to respond to treatment. So, because I can't advance him anymore. He's about at the end of the road there. Is vertical an option? So we did a baseline. You can see he's got kind of a small airway, 2.88, should be 3.25, I think. John will correct me on that. But so he's got baseline. He has a small airway, 2.88. So the minimum was 1.33. You know, I was surprised. It was kind of subnormal. He's got a small airway anyway. Anyway, that's his airway, and we're going to have to work with it. So with the appliance in place, we had a residual volume. It looked like that. He was really bottoming out. So the appliance wasn't, even at that extreme position, he wasn't stable. His minimum went down to 8.88. It's just too small. Okay, so we took an airway metrics vertical titration key, and we went 3, 4, 5, 4 or 5 millimeters, and we took a bite using a bite registration pace at +5, because at +5 things really turn around. And compared to baseline, we were retaining 95% of his airway at residual volume, so that looks favorable. And so we modified the appliance, and look at this. His physician was concerned because he had called him in between visits. He went back for PSG, and this went down to 0 and 0. And that was over a full night study. I've got to get that in here. I was trying to get that study before I came over here. So it was better than this. And I could retrude him a little bit, open them up. He was much more comfortable, and he did much better with less protrusion, a little more vertical. And I wish I had shown, I had the appliance there. You know, Seuss brought this up this afternoon. That's why I ran back. I want to throw this in here. He's talking about when do we decide to do surgery when advancement of the appliance is not working well. And he showed some videos that look at the lateral wall collapsing, you know, and he went in there and he said, if you see this, and you put this with the appliance in place, they're going to have airway surgery. And the question I asked Damien, was, what about if they just do something with the vertical before they decide to do surgery? I mean, it may very well have turned this whole thing around. So this is what we did with Jeff, that last patient. You could do with, this is what I use now. I use the Respire Blue EF, which was fantastic. If you got a patient in treatment for a long time, transition them over to the EF because they're lighter. You can do anything with them you do. But this is what we did with this appliance, and we could have probably done that with that patient who needed surgery. Just add those. It's very easy to do. You know, just this is literally how quickly it took me to put this thing in my mouth. I took it out. It took me 1 minute to get. I like that. It took me 1 minute to deliver that thing to myself. That's how well it's fixed. Fitted, I mean. So I want to show you one last thing. So in summary, I think we've got the technology. We just have to be bold about telling people what we're doing. And, oh, you work SGS? No, I don't work for SGS. I just appreciate what they have available to us. One last comment. Sometimes when you have a Respire Blue and you're advancing, sometimes that when you have that mechanism advance a lot, it disengages at the end. Okay, and I was getting really frustrated with it. Okay, if this kind of thing happens, does it have anybody here? Or it can break loose? Okay, maybe you've come up with this. I just boxed those little platforms, and I just added some acrylic. I showed this to David, and I just built them up. That's just how they look, and I just smoothed it off. I didn't have to do anything but just that and smooth it off. Okay, and it took me about 15 minutes, about 15 to 20 minutes. I like playing with acrylic, but I just built these out a little bit, and those things were no longer going off to the side and maybe busting off, which they had in the past. Anyway, that's what I had for you tonight, and I just wanted to give you some attitude if you're not into this thing with pharyngometry, and just a little clinical tip on the appliance. So thank you very much.